Okay, everyone, let's crack on. Probably got a bit of a confession to make with this one, in that I'm probably going to need your help towards the end, because what tends to happen is when I've done a similar lecture to this before, everyone ends up with a frown on their face and I end up collapsing on the floor. So I'm going to need your help towards the end, but it's okay. Together we'll get through it. Who considers themselves fairly confident with arterial blood gases? Put your hands up. I'm not going to pick on you, so you can do it without fear of retribution. Anyone? Quite confident? Who's sort of semi-confident? Yeah, most people. And who's just not got a clue? Anyone willing to admit that? Okay, fair enough. Okay, but we'll try and get through it. Fine. I want to talk about these kind of things really. Firstly, do you need one? Secondly, how to get it, and then we'll go into how to read it and interpreting it. So first of all, do you need one? And in what sort of situations do you think you might need an arterial over a venous gas? Because we can do gases on venous blood as well. Yeah, but would we need an arterial blood gas to get that information? So say, for example, the patient with diabetic ketoacidosis. Would we need an arterial blood gas? No, we could probably get their pH from the venous gas, and it would tell us the same thing. There are differences between arterial and venous side, and the rule of thumb is it depends on what tissue bed is going between the two sides, but we wouldn't necessarily need an arterial gas. So really, I think you can have a venous gas where you can make a metabolic assessment of the patient with their pH and their bicarbonate, although, you know, there's a caveat, their pH may be a bit lower, so they may be more acidic on the venous side than they are the arterial, if that tissue bed in between them is very anaerobically respiring. But you can't make a respiratory assessment with a venous gas, so that's where you would want an arterial one, is where you want to know their PO2 and PCO2. So what information are you going to get with an arterial blood gas? You're going to get these things. The fraction of inspired oxygen you're not going to get. You need to put that down yourself, so you need to know what oxygen the patient's on, and always note down how they're on it as well. So are they using nasal specs, or are they on rebreathe mask, or whatever? You're going to get the pH, you're going to get the PCO2, and these are normal values next to them up there if you can see those, but don't worry about writing them down, because we'll go through them later and you'll see them on the website if you go there. You're also going to get the partial pressure of oxygen, you're going to get the bicarbonate concentration, and a calculated value of the base excess. You may also get other things like co-oximetry, and that usually gives you a hemoglobin concentration. Also, it works out for you their arterial oxygen saturation. Also gives you a breakdown of other types of oxygenated hemoglobin molecules, or maybe carbon monoxide. So you get COHB. That's quite useful if you're suspecting carbon monoxide poisoning. You know, the lady whose boiler's broken comes in with cherry red lips and breathlessness, that kind of thing. You also get a lot of other information, electrolytes, and their glucose and lactate. Do look at those. ABGs are brilliant in the middle of the night if someone's sick and you just don't know what's wrong with them. Get an ABG, because you get all this information almost instantaneously, or whenever you convince the I2 sister to run the gas for you. So they're really useful. And do look at the other results, because one of the most common reasons for doctors being sued is they order tests and don't look at them. And that includes tests that contain additional information. So say all you wanted to know was, are they acidotic or not? And you got a blood gas that had all of this information on, and you didn't look at the potassium level, and the potassium level was dangerously low. You'd be probably in a bit of trouble. So do look at everything that you do get on the blood gas and know what they mean, how to interpret them. And you also want to know how a blood gas is going to influence your management. Do we need to do one? What will change if we do one now? So if someone's been on non-invasive ventilation, say, we need to support their breathing with a ventilator, doing a blood gas right now, will that change what we do? Will we change the settings? Will we take it off them? Will we, what will we do differently if we had that information? So you may be able to prevent yourself having to do it, but also prevent the patient having a nasty needle in the wrist. I've never had one. Has anyone had one? Apparently they're really painful. Yeah, especially if you hit the bone, which I've done. It happens. So how do you get one? I've already said it's in the wrist, but I'm going to take that away actually. But where do you take arterial blood gases from? Where can you take them? So someone said, everyone's pointing to the wrist. So the radial artery, yeah? So which side is the radial? If I stand anatomically, like this guy. Yeah, it's the lateral side. I'll show you the picture in a moment where it is. But where else can you go? Femoral, yeah. I'm so glad you said that one next. And you can also get the ulnar and brachial as well. And I would do it in this order. So I would go for radial first because it's the most convenient, and groins are dirty places. You don't want to go down there too often. It's not nice for the patient either. Radial's probably better. Then I would go femoral next because it has less complications than any of the others. Ulnar's difficult to find. You may not get it, but some of the cardiologists manage to do angioplasty through ulnar artery, so no reason why we shouldn't be able to get it. But brachial, it's an end artery and has more complications. If you thrombose your radial artery, the likelihood is you won't lose your hand because you'll have a collateral ulnar circulation. Whereas if you do thrombose the brachial artery, you've got a risk of losing your hand. So I would go for the brachial last, only as a sort of last-ditch attempt, and I would go for femoral first and foremost. So the radial artery is there in this diagram, and it's lateral to the tendon of flexor carpi radialis. So flexor is on the anterior surface, does all our flexion of our wrist, carpi, wrist, radialis, it's on the radial side. So the lateral side of the wrist on the flexor compartment, and you can feel that tendon yourself, and I would, in patients, feel that, and then feel the styloid process, and sort of somewhere in between there you'll find the radial artery. It's quite easy to feel on yourself or your friends. So that's where to find it. And I give you the anatomical landmarks because in some people who, let's say, are not particularly calorie challenged, it's quite difficult to find the radial artery. So anatomical landmarks are useful. Who's heard of an Allen's test? Hands up. What is it? Yeah, it's really long. It's not a one-word answer. But basically what you do is you test for collateral ulnar circulation by compressing all of the blood out of the hand. And you compress the radial and the ulnar arteries at the same time, and you release the hand, and it will be white because there's no blood flow going to it. And then what you do is, with your finger still on the radial, you release the ulnar. And if the ulnar is patent, you should get reperfusion of the hand. It'll go nice and pink. And the reason for doing that, or the thought behind doing that, is that if you do thrombose the radial or cause a problem, then you won't lose the hand because there'll be collateral ulnar circulation. But who does one? Does anyone do Allen's test? So how many of you have taken a blood gas? So how many of you have always done an Allen's test? Yeah, I mean, I don't always do it, and there's a rationale, or a sort of line of thinking now to say that maybe you shouldn't do one, maybe we don't need to do one, in that some of the cardiologists don't do it when they do primary PCI, not primary PCI, but PCI through the radial artery, and they say that everyone's got an ulnar artery, but if you thrombose your radial, that's when the ulnar opens up and becomes more dominant, and you probably should do one. Let's just leave it at that. And when you take a gas, you should always stick them in the notes, but they're always printed on thermal paper. So when the secretary is typing up the notes from clinic and she puts it on the radiator, it'll go all black and you won't be able to read it anymore. So do write them in the notes yourself. Stick them in, write them in. Also shows that you've looked at it. And note the time that you've taken it, because that's really important. So the time you've taken it and how much oxygen they're on, because if they've got a PO2 of 9 on air, not so bad. If they've got PO2 of 9 on there and 15 litres, a bit worse. And also note the peripheral oxygen saturation, because you'll come back with a gas sometimes and you'll think, was it venous? Could have been venous. Not sure if I did it right, could have been venous. Whereas if the oxygen saturations on the probe when you took it are similar to the oxygen saturations on the gas, you can be more confident you've taken an arterial sample. So it's useful to do that. And also, you'll get a feel for how useful oxygen saturations are when monitoring that patient. If they're completely wildly out, then you might not consider oxygen saturation or pulse oximetry monitoring that useful for that patient. And do look at all the numbers for reasons we've said earlier. Okay, that's about how to get one. Now we'll go through the not insignificant task of going through how to read one. And when everything gets complex or complicated, you'll see Ed and I walk over here and stare at the screen. So you want to do 3 things. First, assess the oxygenation. And there are loads of different ways to do this, by the way. And for those of you who already have a system with arterial blood gases, I don't want to confuse you. Keep to your system because it's yours and you should only add to it or change it if you feel necessary. But this is the way I do it. So first of all, I assess the oxygenation. Secondly, decide on their acid-base status. And thirdly, decide is there any compensation at all from any particular system. So here's the information we're going to get again, just as a reminder. We're going to note the FiO2 ourselves. We'll get the pH with normal value 7.35, 7.45. PCO2, 4.7 to 6 is the normal. PO2, 11 to 13 is normal at breathing room air at sea level. And bicarbonate concentration 24 to 30, something like that. And base excess usually plus 2 to minus 2. That's not the right keyboard. What is pH? So is everyone sort of okay with pH? It's the minus log of the hydrogen ion concentration. Remember, hydrogen ions are acid, so more acid, lower pH. So a low pH is acidic, a high pH is metabolic. And you remember this equilibrium here, so that carbon dioxide and water is in a dynamic equilibrium between bicarbonate and hydrogen ions, which, again, as we said, is acid. So that's important to remember when you're thinking about causes of things. So step one, assess oxygenation. Respiratory failure is defined as a PO2 of less than 8 kilopascals. And the arterial PO2 depends on the alveolar PO2. So if you went up a very large mountain, the air was very thin, and you're breathing hypoxic gases, then you're going to have a low arterial PO2. And there are lots of reasons why people may be breathing hypoxic gases, but just remember that whatever's coming in, you're trying to compare it to whatever's the PO2 that you're taking from the artery. So always compare what they're breathing to the arterial PO2. And there are equations to work this out, to say, is the PO2 that we see measured appropriate based on what they're breathing through their mouth. So you can use the alveolar gas equation, and that's favoured by loads of anaesthetists, or you can just take a really simplistic view and just look at the FiO2, which is a fraction of inspired oxygen, compare it to the PO2. So is their PO2 appropriate to what they're breathing in? So if I said someone has a PO2, we'll use the example I used before, someone's got a PO2 of 9, if they're breathing air, then that's kind of a bit low, but kind of appropriate, isn't it? Whereas if they're on 15 litres of oxygen via a non-rebreathed mask and their PO2 is still 9, that's more worrying. So always look at that ratio and think about it in context. Is it appropriate for what they're breathing? How sick are they? And the difference, you can work it out in health, is approximately 10 kilopascals. So say we said the normal value, what was the normal value of PO2? 11 to 13, okay. So what's the fraction of inspired oxygen? What's the partial pressure of oxygen in air? 21%. So minus 10 from that, and this is just a silly rule, but it's just a quick sort of mental head check to say, does this make sense? So subtract 10 from 21, that's what I'm breathing in, and that gives you a value of 11. So that's kind of what my arterial oxygen content should be. Yeah? Does that make sense? And also that PO2 is not SaO2. So the partial pressure of oxygen dissolved in your plasma is not how we carry oxygen. We don't carry oxygen as human rounds in our plasma. That's not how we use it. It's there, but it's not how we use it. We carry oxygen bound to hemoglobin, and the percentage saturation of that is your SaO2. So just bear in mind that you're not directly measuring the way that humans carry oxygen around when we live, and that's not how we give oxygen to our tissues. So PO2 is not SaO2. It's just a sort of surrogate marker. So SaO2 is important as well, and that's important for some situations where you've got someone who's got a very low PO2, but their saturations are quite well maintained, and you'd be less worried about those people. It's a bit specialist, but don't worry about it too much. And there are two types of respiratory failure. There's type 1 respiratory failure, and there's type 2 respiratory failure. And the difference between the two is that you've got a raised CO2 in type 2 respiratory failure. So type 1 respiratory failure, you've just got a low oxygen concentration, where in type 2 respiratory failure, you've got both low oxygen concentration and a high CO2 concentration. I'm going to explain that by taking you through the three causes of hypoxemia. So in general, I'm going to take a sip of water. There are three causes of a low oxygen concentration in your blood. One is a shunt, so maybe a hole in the heart, maybe a pulmonary embolism, something like that. 2 is reduced diffusion capacity, so that may be fibrosis or something like that. And 3 is hypoventilation. So which one of those is most commonly going to give you a type 2 respiratory failure? So again, someone shout it. The third one, hypoventilation. But why don't you get a type 2 respiratory failure with a shunt, like a pulmonary embolism? Because a pulmonary embolism, we usually get type 1 respiratory failure, don't we? Why don't we get a type 2 respiratory failure? Why is it that the oxygen level's low, but the CO2 is not high? Say again? Kind of. But any type 1 respiratory failure, if it's bad enough, will result in a type 2 respiratory failure. But say we had a pulmonary embolism and we took out the bottom segment of my right lung, no longer active. So much so that my arterial oxygen concentration would drop as a result of taking out that part of my lung with a big clot. CO2 is 20 times more soluble than oxygen, so CO2 will still get expired by the rest of my lung. So my rest of my lung can compensate for that, but it can't get enough oxygen in to keep my PO2 up. Does that make sense? Whereas hypoventilation, no gas is coming in or out. So you're not going to get rid of your CO2 because no gas is coming in or out. Absolutely no gas. So that's why hypoventilation causes type 2 respiratory failure. And that's why you don't get, or don't usually get, a type 2 respiratory failure with a shunt. Make sense? Cool. Okay, let's move on. So type 1 respiratory failure, let's have a look what that looks like in terms of numbers. So if we've stabbed someone in the wrist and we've got this, breathing FiO2 of 21%, that's air. Their pH is 7.44, so that's normal. Okay, and let's have a look at their O2. Let's forget everything else at the moment. Their O2 is 7.5, and we said our normal is 11 to 13, so that's low. And is it type 2 respiratory failure? Let's look at the CO2. No, it's kind of low, so it's not high, so that's type 1 respiratory failure. So look at the oxygen, it's low. Look at the CO2, that's sort of low or normal, so it's not type 2, it's therefore type 1. Okay, let's look at type 2. So first of all, they're breathing air. Let's look at the PO2, that's 7.5. So it's low, same as we had before, but this time we've got a PCO2 of 10, which is high because it's above 6. So therefore that's a type 2 respiratory failure. So their CO2 is raised as well. That's it. So that's oxygenation done. So we can stratify them into a type 1 or type 2 respiratory failure. The second thing we need to do when we've got our big blood gas is to decide on their acid-base status. And the first question you should ask yourself is, what is the pH? If it's less than 7.5, then it's acidemia. If it's greater than 7.45, then it's alkemia. The second question after you've decided, is it an acidemia, normal, or an alkemia, is to try and work out what's the cause. Is it respiratory, or is it metabolic? And you can, this is the way I do it, there are other ways, but you can look at, what I do is I look at the CO2 and think, is that responsible for this level of acidemia or alkemia? And if it's not, then I move on to looking at the bicarbonate concentration and then trying to decide, is that responsible for this level of acidemia or alkemia? And let's just see an example of that. So in respiratory, let's just take respiratory as a particular entity. A respiratory acidemia would be caused by a raised CO2 because carbon dioxide is an acidic gas. And a respiratory alkemia would be caused by a low CO2, so that you get in hyperventilation, you get a very low CO2, and you get a respiratory alkemia. And if you look at the blood gas and your level of pH deviation is not explained by the carbon dioxide, then move on to the metabolic side. So you will look at your bicarbonate and decide, is your bicarbonate or metabolic status of the patient responsible for that level in pH change? So look at the bicarb. And in a metabolic acidosis, you'll have a very low bicarb. So someone who's diabetic with ketoacidosis will have a very low bicarb. But kind of their CO2 would probably be low because remember they get the Kussmaul's respiration, they breathe very rapidly. So they'll have a low CO2. So you'll look at you'll see someone with diabetic ketoacidosis and they've got a pH of 7.25. They're acidemic. You'll look at the CO2 and it will be low. Okay, so that's not responsible, is it? That's not causing the acidemia. So then you'll look at the bicarb, and the bicarb will be low, very low. And then you'll think, yes, that makes sense. That's responsible for this acidemia. They've got a metabolic acidosis, and it's the ketones that cause that in diabetic ketoacidosis. And conversely, if they're alchemic, have a look at the bicarb, see if that's responsible. Hope that makes sense. All of that is complicated by the fact that the body doesn't like being acidemic or alchemic. It messes up our enzyme systems, cells don't function properly, makes us feel horrible, and we have to come into hospital and see doctors. So the body generally tries to compensate for things, trying to maintain its internal environment, the homeostasis, if you like. And there are two types of compensation: respiratory. Respiratory compensation we can assess from the end of the bed. It's basically respiratory rate. And metabolic compensation, which we can't assess from the end of the bed, and we need a blood test to help us determine. So, as ventilation increases, PCO2 decreases and vice versa. So if you stop breathing, like you will know when David Blaine did his stunt where he held his breath for something like, was it like 17 minutes? That's insane, isn't it? 17 minutes was it on the Oprah Winfrey show? That's impressive. But his respiratory rate was essentially nothing a minute, actually less than that, because it was for 17 minutes. It was nothing for 17 minutes. So his CO2 would have been climbing and he would have been suffering problems of a high CO2. Whereas someone who's very anxious and hyperventilates will breathe off lots of CO2 and their CO2 level will drop. And the respiratory centre is sensitive to an acidosis. So in the diabetic who's got ketones and they're acidotic, they're sensitive, because they're acidotic, the brain center stimulates respiration, so they breathe very quickly. That's why you get the Kussmaul's respiration. And that's in an attempt to blow off CO2. So if that person who was diabetic with ketones and acidotic blew off all their CO2, they may be able to compensate for the acidosis going on in their blood by breathing off the CO2. And remember, CO2, when the level goes down, it makes us more alchemic. So they're kind of balancing themselves out. So we can assess that from the end of the bed. So it's always important to write down the respiratory rate when you take a gas. Okay, that's respiratory compensation. I've kind of already explained that, haven't I? Yeah? So as pH decreases, as you become more acidic, you breathe faster in compensation. So it's a rapid response. It happens immediately. So if I were to go up to someone and give them a big intravenous dose of acid, that would make you breathe very quickly, almost instantaneously, because it's controlled by the brain. And it's accessible from the end of the bed. Okay, metabolic compensation. So bicarbonate is the major buffer system in the blood, but there are others. So hemoglobin itself is a buffer system, and there are some other proteins and things that help. But bicarbonate's the major one. And the kidneys secrete hydrogen ions, and they also filter and resorb bicarbonate. So the kidneys are the ones that are going to be doing most of the compensation. So there is a buffer system that helps, but once we oversaturate that buffer system, it's going to be the kidneys that are going to help us compensate metabolically for respiratory acidosis. So think of your little old lady who smoked 3 packs a day for 60 years, and she's got COPD, and now she's in an acute exacerbation. She's got type 2 respiratory failure with a really high CO2. Her kidneys are going to be working like mad to try and return her blood values to normal. The kidneys try and help, and this is a slow response, and it usually takes a day or two for the kidneys to get going. So it lags behind, when we saw with respiratory compensation happens very quickly. Metabolic compensation via the kidneys happens quite slowly. It lags behind any changes in the pH. So it's important to when you're tracking serial changes, to just realise that fact. Was it supposed to do that? It was? Good. Okay. This is where I'm going to need some help from you guys. But before we move on, I just want to ask, is everyone okay with the concepts? Is everyone okay with what we're going to do? So remember, we're going to assess the oxygenation first, aren't we? Then we're going to look at the acid-base status, and then we're going to decide, is there any compensation? So I'm going to need 4 volunteers. Does anyone want to come down? Don't worry, I'm not going to ask you very difficult questions or anything. I just need 4 people to come to the front. Is anyone willing? No? You guys want to come? You 3? No? Not at all? Any this side? Come on. Well done. Round of applause for you coming down. One more. Let's do it. No, there's no question. I'm not going to ask you questions. Well, you will have a role. You will have a role. But I'm not going to ask you any questions as such. So space yourselves out a little bit and stand across the front. Right, let's go here. Let's look at respiratory acidemia. Now, you, my dear, are pH, okay? And I want you to be normal, low, or high. Yeah, both hands in the air, unless you've got sweat like me. So that's what. In which case, you can do it. You can be partial pressure of oxygen, carbon dioxide, and bicarbonate. Happy with bicarbonate? It's a bit of a rubbish one, isn't it? Oh, sorry. Someone has to do it. Okay. Respiratory acidemia. What do you think? What are you going to be? You're going to be low. Okay. You have to stay like that. Have you done the skiing thing? You're going to stay like that. Or do you want to swap? Okay. So you're going to be low. And sorry, I forgot your name. Sorry, what were your names? Your D. Okay. And Sam, what are you going to be, Sam? So you're oxygen. You're going to be high, low, or normal. So you're going to be low, okay, get down there. And so what was your name? Naomi. Okay, what were you? You were CO2. Are you going to be high, low, or normal? No idea. So respiratory acidosis or respiratory acidemia. So you're going to be high. So you have both hands in the air. Okay, keep it up. And bicarbonate, what are you going to be, high, low, or normal? Depends, doesn't it? Depends. So depends whether on what? So whether there's any compensation or not. So say it's been going on chronically. Let's say it's happened immediately. So they've got type 2 respiratory failure. It's happened within the last couple of hours. You're going to be normal or low. Yeah? But if it's been going on for a long time, yeah, you can just be like, nah. You're indifferent. Doesn't matter. Depends on the compensation. Fine. Okay. So let's have a look at that. Okay, you can relax, guys. So let's have a look. So FiO2 of 0.21. What are we going to do first? What's the first job? Oxygenation. Okay, let's have a look at oxygenation. So their PO2 is 7.5. So that's low, isn't it? As you know, Dee said, it's low. So that's respiratory failure. Is it type 1 or type 2? What do we need to do to decide that? Look at CO2. High, low, or normal? High. Okay. High CO2. What's that called? Type 2 respiratory failure. Brilliant. Okay. Then that's it, isn't it? So we've diagnosed type 2 respiratory failure. Now we need to assess acid-base status. Brilliant. So what do we do to look at that? Okay, so Sam was pH 7.2. High, low, or normal? Low, yeah. So this is acidemia. And then we need to decide what's the cause. Is it going to be respiratory or is it going to be metabolic? Well, we know it's respiratory, but why is it respiratory? It's respiratory because we first look at the CO2. Is PCO2 of 10 responsible for an acidemia of a pH of 7.2? Yeah, could be, couldn't it? If the CO2 was normal, then you'd move on to bicarb. But I think that explains a PO2 of 7.2 quite well. So that's it. So acid-base status, they're an acidemia, and respiratory acidemia. So this is type 2 respiratory failure, and it's respiratory acidosis. And then the third thing we need to do is assess whether there's any compensation. So Miss Bicarb over here is going to be normal because the bicarb is kind of normal. But you would expect it to be low, wouldn't you? Because you would expect them to be acidotic and their bicarb would be low. So maybe they are compensating a little bit. So it's sort of early compensation, I think. So type 2 respiratory failure is a respiratory acidosis, and there's possibly a little bit of compensation, but they're decompensated because they're still acidotic. Make sense? Cool. All right, let's go through another one. So you guys are still needed. Metabolic acidemia or acidosis. What's the difference between acidemia and acidosis, by the way?
It's acidemia when it's high, but there's no symptoms.
Not really, no. Yeah, so anything emia is blood, isn't it? So like leukemia is leukocytes in the blood. So an acidemia is an acid in the blood. And this is sort of technical stuff that anaesthetists get really funny about, and most people just generally say acidosis or alkalosis. But if you say acidosis or alkalosis, that's implying that a particular tissue bed is either in an acidic or an alkaline environment, whereas an acidemia or an alkemia specifically talks of the blood. So it's probably right to call it an acidemia, but it's a bit pernickety. I wouldn't worry about it too much. So, metabolic acidemia, pH? Oh, you guys move here? Oh, okay. Not on the stage. Okay, I'll go up here then. Okay, D, what were you? So metabolic, your pH, aren't you? So you're going to be low. Sam, what are you going to be doing? Metabolic acidemia. Any ideas, guys? All right, think about our patient. You ever get stuck? Think about a specific patient. So let's think about someone who's acidotic. So diabetic ketoacidosis. Hands up who thinks high. Who thinks high? Who thinks normal? Who thinks low? So it depends on how much compensation there is, but it's probably going to be low, aren't you? So sorry, you have to get down again. PO2, diabetic ketoacidosis. Are you? Oh, have I messed it up? Oh, so you're what are you then? If you're PO2, then you'll kind of be normal, won't you? Oh, sorry. Did I say that wrong? Is that why you're looking really confused? Oh, I'm really sorry. I'm glad you've caught me out anyway. It shows you're on the ball. I usually throw these little things in now and again just to see if you're awake. Yeah, PO2 is normal. Yeah, quite right, quite normal, or maybe even a little bit high. So you're CO2. That's what I was talking about. So CO2, you'll probably be compensating quite a lot, and you'll be low. So now you have to go. Oh, very clever. Okay. And bicarbonate. Yeah, you're going to be really low, aren't you? Because it's metabolic. Someone just lay down. Okay, so let's have a look at the blood gas. Okay, so if you guys can turn around. So let's have a look. So it's a metabolic acidosis or acidemia, whatever you can call it. pH is 7.2. Oh no, we were going to start oxygen, weren't we? So for step one, see, I even forget my own system. Step one, assess oxygenation. So high, low, or normal, PO2. So normal, as you know, you guys quite rightly picked out. Sam wasn't supposed to do anything. He's supposed to stand there and look pretty. So it's normal. Okay, so we don't need to go into, it's not respiratory failure, so we don't need to bother looking at the CO2 here. And then we need to assess our acid-base status. So we look at the pH. It's acidemic, isn't it? 7.2. Is the CO2 responsible for that level of acidosis? Well, no, it's low. It's 3.3. There's no way that CO2 of 3.3 can cause an acidosis. So we move on to the bicarb. So can the bicarb cause that level of pH deficit? pH change? Well, it's low, so yes, it could. So this is a metabolic acidosis. And is there any compensation? That's the third thing we need to look at. And the CO2 is low, so yes, there is some respiratory compensation. So this is a metabolic acidosis with respiratory compensation, and there's no respiratory failure at all. So that's it. Okay, thank you very much, guys. Round of applause. Thank you for helping me. Now you can applaud those guys as well. No, I'm joking. So that's it. Look at this as well, normal and high ion on gaps. I'm not going to go through that now because it's just too intense. But it helps you stratify, there's the formula for it, and you can see this on the website, but it helps you stratify a metabolic acidosis into a normal or high ion on gap, and therefore you can determine the causes. But that's something to read up on your favourite textbook or Wikipedia or whatever you do. Okay, so step 4, after you've done all of that stuff, is to go back to the patient with your interpretation. If you want, you can close your eyes and think about people standing up and hands in the air and everything else. But once you've made your assessment and your diagnosis on the blood gas, go back to the patient and look at them, put it all in context and think, does it make sense? And decide what you need to do about it. If in doubt, ask a senior. Thanks very much.